Again, patients really need to be encouraged to discuss their feelings and thoughts in a very open-ended way. Um, it's important that you spend concentrated time with the client and the family. And as we know, many nurses have very heavy assignments, and so sometimes that is very uncomfortable because you're trying to take care of that situation, and then you've got other patients that need your support as well. So it's important to really, when that kind of situation is occurring, think about who are your support systems. Maybe you need to go to your charge nurse that day. Maybe you need to contact even the nurse manager and just let them know that we have a situation where someone's really struggling emotionally about, spiritual concerns. And then most hospitals are going to have access to kind of a neutral chaplain that can kind of give some people some kind of non-denominational guidance in terms of, not to be prescriptive and tell them any specific religious tenets, but more along the lines giving them some ideas as to how they can explore some of their dilemmas and things when it comes to spiritual concerns, and kind of guide them to find ways to answer their questions, and maybe in that way just kind of lower their level of distress. Sometimes family members will be very clear that they have their own religious leader that they would like, and of course that's usually preferable to the chaplains in the hospitals. And often, even if you do call a chaplain in the hospital, their goal is not to really be very prescriptive about any one religion. They should be kind of ministering to the needs in general, and then they should also be identifying that the person would prefer their own religious leader, and then helping facilitate them have that person come in and meet with them and help them in that way. The main thing to think about with spiritual distress is we want to be there for the patient. We want to encourage them to talk and spend time with them. The other piece is the nurse's role is to be an unbiased advocate. And so in that way, we all have our own religious backgrounds and beliefs. So it is really not appropriate to, discuss specific things with people or encourage them one way or another. If they're specifically asking you a question and you're of a specific faith and you can answer that question, that's different than if you are, in there semi-preaching to them about your beliefs. So just remember that this whole circumstance is not about you saving somebody. It is about them going through the process so that they can come to some resolution, and you can give them guidance as well. You can give them support people. You can get them a Bible. You can do different things that they might need or want without bringing your own biases into that situation. So just be advised of that. Last of all, I want to kind of just differentiate once again a little bit about do not resuscitate directives. You will see a combination of this here in our state. We have living wills that patients may enact at any time on their own, and those are legally binding with certain circumstances, and I'll discuss that. You may have what we call the North Carolina Most form, and you may see actual do not resuscitate orders in a computer system, but you may also see them as a paper form for both the Most and the DNR. And the reason for that is those are portable, meaning that if you transfer a patient from one unit or one hospital to the next or to another facility, if those are all in order, most agencies accept those and go by those without the patient having to have another doctor write a whole another order. So always check with the agency policy on the use of those and whether they accept them unanimously. But that is the intent of those, to have that be usable for that reason. So this is just some details about living wills and healthcare power of attorney. Both are considered advanced directives, meaning that the patient's really the one who has to be oriented and competent to complete that and denote what they want done in terms of, what do they want done at their death if they have a terminal incurable disease, and then who, if anybody, they would like to assign the role of healthcare power of attorney, meaning only that they can make healthcare decisions for the person if, as a context, they become incompetent to make decisions. So if you ever have a patient's family member come to you and say, well, I'm here because Mama's going to sign her living will, and Mama's not been competent the whole time she's been there, we as an advocate need to bring that to someone's attention, because they can't be going in there and doing that under our watch. So just know, advanced directives in terms of living will and healthcare power of attorney, the person must be competent to enact those and cannot be done by a family member. Another key thing to know is, on admission, Joint Commission requires the admitting nurse to evaluate the patient's wishes related to advanced directives. And if they find that the patient has an advanced directive, they have to ask for and document that they have asked for a copy to be obtained, and when one is provided by the patient or family, then that is put on the chart, or it may be, for an electronic standpoint, scanned into the medical record as well. And then the MD needs to be notified of that so that they can review it, and if the agency wants an electronic order related to a code status, then the doctor can enact that way. If the patient does not have these documents, then the RN has to document the patient's wishes in the record and notify the doctor if a DNR or a limited DNR is desired, so that they can again come and reevaluate and determine competency and take care of the order forms or whatever is needed. The RN also must document that the patient was asked if he desires education on advanced directives and his response. So there are specific forms that are provided and given to the patient on admission so that they could fill out. It's like educational material related to that, like a brochure and or the forms that are available from the state for both a healthcare power of attorney and a living will. And if the patient doesn't want them, then you don't have to give them to them, but you need to offer it and you need to document that it was offered if it's appropriate. If not, that really breaks some standards, because we're required to do that for years now. For most hospitals, there will be, if the person is wanting teaching, there'll be like an automatic consult to social work or chaplain. They'll have a designated position that usually comes and provides that education. We as nurses are legally not able to sign as a witness for a living will or a healthcare power of attorney for a patient in the hospital. The hospitals will all have that rule. That's just to legally not have the agency bound up in anything that comes out of that document being enacted. So you may sometimes have people ask you, can you come in here and be a witness? Do not, under any circumstances, do that. The other thing is, you may see, the ruling for that here is your witnesses have to be two people who are not related to the patient by blood or marriage in any kind of way. And so in small communities, sometimes that's difficult because a lot of people are related. So they may go walk down the hall and find some visitor and say, would you come down here to this room and be a witness? And that's perfectly fine. They don't have to do it, but if they're willing to do it, they can. But they cannot be related to them by blood or marriage. These are the two forms, and I won't read you all the nuances of those, but basically the most form is really more for patients that have specific things they want done. Okay, maybe they want one thing done but not the other. Maybe they want compressions but they don't want drugs, or they want, to be put on a ventilator but they don't want chest compressions, or so it gives the flexibility, and it also has many categories about whether they would want hydration, nutrition, other types of things that could be enacted. The nice thing about this form is most agencies and EMS have agreed that both of these two forms, if they are a legitimate original that's provided to them, then they will follow that no matter where the patient is. And because it's got a doctor's order and it's signed by a physician, then it's an order, period. And so that's a good thing to have available so that you don't end up coding somebody who didn't need to be just because of where they were. So these are just some of the specifics. Your do not resuscitate order is the yellow form, and it is North Carolina specific. Orders on all healthcare providers to not resuscitate a patient. And note that this is at the time of cardiac or pulmonary arrest. That doesn't mean that we don't render care up until there's an arrest. So if somebody is, coughing and choking and aspirating, yes, we're going to suction them. It doesn't mean we just let them sit there and do that. So just be aware of kind of the nuances of that, but it is in our general statute, and I put you the number there. I would also encourage you to look at the forms that are there and kind of read through them so you familiarize with what's on those forms, what has to be filled out, and by whom. It's very explicit, and you have copies of all of these in under Week 13 resources files. So the RN does have a role in ethical and legal advocacy. Here's a good example of kind of showing that process in terms of, engaging with the family, being there for them, allowing them to have things that really soothe and make the patient have a very dignified death. And sometimes families might ask for something unusual like this, bringing harps in to play, or taking the patient in their bed to something to look out the window, or sometimes they'll allow them to bring their pet in from home, or different things. So always be concerned about what is the right thing to do for your patient, what's the legal thing to do, and always try to look out for your patient in a sense that they're in a very weakened and debilitated state. And sometimes there are unscrupulous people who do try to take advantage of people at this point in time. So we have a protection standpoint for ethical and legal matters, but we also need to have a huge supportive help in making death that is inevitable a situation that can be the best it can be under the circumstances for the patient and the family. Last thing I wanted to mention, even though it's not a slide on here, I will give you some information in terms of some specific things that you might see on your study guide. I'm going to try to give you as much detail of examples of things to look up, so don't get disenfranchised with me, but I think it's important for you. There may be some different medications or different things that you may give a certain way for somebody who's in a dying process. And so I may put some of those on your study guide instead of putting them here, just because I feel like you'd probably spend more time with it there than here. Thanks.